So always, whenever possible, if it is available, see the reformatted image. You will get an idea about. See the bone loss. See, till the basal bone already natural has done alveoloplasty. So we don't have to do any much alveoloplasty. Maybe we need to do some minimal bone leveling. Maybe here and all. So these kind of cases will bleed very much. So bone wax should be ready. Better if you have cautery also, that will be good. So this side it is in the second premolar mental foramen. This side is also in the maybe in the between second and first premolar. Whatever it is, we don't worry. We have to open the flap here. So placing incision and opening the flap will be a challenging here because tissue may be adherently attached to it. If it is a multiple extraction and the flap reflection, it is quite easy. But this kind of perio cases, healed cases, tissue will be adherent. But the ridge is quite wider. No, it is not a thin ridge. In a way, it is good. Sometimes, rarely you see double mental foramen. Very rarely, we saw only 2 cases. There is complete absence of mental. No mental foramen. It will be like smooth, polished. Okay, then I went and searched some articles. Some rare case reports are there. Complete absence of mental. So this kind of variations you can observe. Now we'll plan in the panoramic view. So comparatively, this side is less, this side is more. We may have to remove a little bit of here. This is mental foramen, this is mental foramen. In between mental foramen, 4 implants. Here 1 or 2, because less bone is there, better place 2. Here good bone looks there, you can place 1 or 2. And always look for whether you can place implant exactly over the mental foramen area. Sometimes it is possible. Okay. So we may plan for 8 implants for this patient. The main reason why we are placing 8 implants is because he is very young. He is around only 38. So why to take the risk? Okay. 6 implant is enough, but so bone shape is good, very ideal. Buccal width is more. The bone quality is good. We can select a. When you are placing 8 implants, you don't have to worry about selecting larger diameter. 3.75 is enough because we are placing multiple implants. Placing 3.75 is actually easier than placing a 4.2. 4.2 may get stuck somewhere, you have to drill more. 3.75 is very easy. Most of the time, almost 80 to 90% we use 3.75. Same thing in clinic, you need this kind of buffers. Okay, so to handle this kind of challenging situation, all situations, if you go and handle with the patients, then it will be very difficult for you to concentrate on clinical aspect. Our main aim is to reduce this kind of problems actually. But if it problem comes, there should be some team in the front, to take the buffer either in the reception or somewhere else. If we take all the forces, then it will be like traveling in this kind of thing. So first premolar implant, the bone is very good actually. Buccal very ideal. You cannot make any mistakes. The shape is not very much. Previously, maybe when the teeth was present. Okay. It may be like this, right? But after alveoloplasty, it is now ideal for us to drill. If the shape is like this, doing drilling here is tough. You may perforate, but here you cannot perforate it. Most of the time, the lingual perforation is due to this shape. That is why in full mouth cases they are less complicated because anyway you are going to do alveoloplasty. This problem is avoided. When you are doing partial implant, you are removing only 4 inches and you are placing implant. Then you have to be very careful. So whenever if you extract and place implant, that means you are drilling like this. You cannot drill like this. But when you do alveoloplasty, you can drill like this. So this is also straightforward situation. This is 3-2. We will see this is exactly in the midline. This is exactly in the midline. You can see this going inside and okay. If you drill exactly in the midline and if you perforate here, the vessel tears here, then it will So that is where the problem. Lingual perforation is avoid and avoid midline implant. If you do both the mistakes, midline and lingual perforation, that is where the complication are. So there are some nice articles about this lingual foramens, accessory foramens. Only about this article is there. Interforamina planning for implants. After some time you will get bored planning lower jaw, right? It will be the same story. First premolar one, next to midline 2 implants, first premolar one. But the variations come in the distal mandible. Okay, extraction is something different, heel care is different, bone level is different, canal position is different, lingual myeloid anatomy is different. So that is where a lot of variations come. So we'll plan exactly over the mental foramen. It is also good, actually you can place a short implant. It shows 10, but you can place a 8. It's a good placement. So expose the mental foramen exactly above the mental foramen.
Sir, மேல ஒரு கமாண்டியூன்ட்டா இல்ல ரெகுலரா சார்?
Regular தான்.
ஓகே ஓகே. இப்போ டெரிகாய்ட் போட போறோம் அப்படினா லோ ரேட் இன்டர்ஃபியர் ஆகுமா சார்?
டெரிகாய்ட் போட மாட்டோம். அப்ப okay. So this mental foramen above the mental foramen we can place. We should not miss it. So that this is almost on the distal root of 6. See, the challenge starts. It's not very ideal, no? The crestal bone is very poor. Okay, almost there is no crestal bone. Maybe you recently fall out teeth. But lingually, you can go. So we will see in the 7 area. It is in the 7 area. The 7 area looks better. Okay, myeloid ridge, lingual wall, this fossa, nerve. You have got a good safety distance to perforate. Keep finger here. Do the drilling along the finger. At the same time, feel the drill coming out. 3.15, 10 something we can place. It shows 9 mm. We can place 8 mm and over insert it. Okay. So whenever you are dealing with the distal mandible, immediately this finger go on to check the myeloid ridge. That's it. That is our CBCT. Chip and West inbuilt CBCT. Right? Okay. Even if you don't have a CBCT, this will tell you where is the myeloid ridge, how much is this. Previously, maybe above, before 10 years, this patient, if you have taken CBCT, it will be like this, the bone level. Okay. When the bone level is like this, it is difficult to do lingual cortical engagement because you have to put your finger very deep. You have to travel long distance. The more the resorption, the more easier you can feel and coordinate. Okay. So the more resolved cases, conventional doctors they get no hesitant. But actually, if you know lingual cortical engagement with small minimal diameter implants, you can easily. So left side premolar, you will check. Here also the bone is good. Anyhow, we are going to do alveoloplasty.
So distal to 6, I mean to say the 7 region, where the lingual cortical, we have a
okay, actually, yeah, please.
we have a good, you said in this ideal case where the bone is there, missing, trying to restore for the upper tooth, we'll place 7. In this, we no need to go like this, right? For lingually, when we have an ideal bone,
No, straight, just straight.
Straight, that
Straight,
is.
straight. Intramedullary replacement. That's enough. So when you see CBCT, this kind of cases, just imagine how the anatomy would have looked before all this resorption, all this extraction is done. Okay. See, the main base is the surgical anatomical knowledge. If you have that, you can approach confidently with or without CBCT. Otherwise, it will be a trouble. That's what I used to tell. There are only 4 segments in our mouth: anterior maxilla, distal maxilla, anterior mandible, distal mandible. Take only one segment. For 1 month, read only about that. Think only about that. Then next month, think and read only 4 months. Then done. Okay. Both sides, we are going to use the mental foramen area. Lingual wall, myeloid ridge, fossa, nerve. Stay along the lingual bone. So only here, don't start from here. If you start from here, you have to come like this. Okay, this is much easier. So here even the crestal bone is good, the intramedullary bone is good. Even if you don't perforate also, no problem. Even if you stop your implant till here, it is okay. So whenever you are doing lingual cortical perforation, always select 3.75 compressive. Don't select 4.2. Okay? Why means, see this is the tip of the implant. Okay? The 4.2 may be bigger. This is 3.75. So this tip only goes here. Okay, if it is narrow, it will easily engage the lingual cortical. So don't select a bigger diameter implant for lingual cortical engagement. Either 3.75 or 3.6 basal. I prefer mostly 3.75 because even though it is 3.75, in the tip it will be only 1 mm. But if you use basal, here it is 3.6. Okay, so this is our safety value. So if I place compressive, only 1 mm implant part comes here. If I place 3.6 basal, 3.6 entire thing is coming. If I do some mistake, it may touch the nerve also.
Okay, sir.
Wait for
Lunch முடிச்சிட்டு வரலாம்.
lunch முடிச்சிட்டு. So challenges list. Flap elevation, we may have difficulty. Flap elevation, sharp elevator is a must. Otherwise, we have difficulty. Bleeding. Maybe large tongue patient may be having. Okay. What else? And alveoloplasty, we may have to use the burr because the bone is quite dense. You cannot use the Ranger forceps. So whenever you are using, burr, you should be very careful. If you saw clearly, that burr got stuck in my gloves at one moment. Okay. So the same way it may tissue also. And one difficulty we may face during surgery is if there is lower anterior tooth is present, we may take this socket outline may be present, little bit socket outline. Even if it is present, we may take it as a guidance. Oh, we will know this is 3-4-2, this is 3-2. But when it is totally edentulous, we don't know where is the midline first. We don't know where is the socket outline. That challenge will come. So how to avoid that is, before starting incision, you see the lingual frenum and put a vertical incision here. So we are doing crestal incision. Apart from that, if you do vertical incision, that will serve as a midline mark.
Then we give us a guidance in such cases.
Yes.
So both we can take it out, even buccal frenum and
Yes. Out of interest, we will draw the nerve here. The nerve is beautifully seen here. When the bone quality is good, you can see the nerve. This is the railway track appearance. And one more interesting feature in this patient is, even this is the mental foramen area. Even after the mental foramen, one part is extending. That is nothing but the incisive canal. The inferior alveolar nerve comes here, vessel. It goes out, mental nerve, but it travels inside the bone, very small incisive nerve. For some patient, incisive nerve will be very thick. You can see clearly in the mandible. For some patient, you cannot see it. Okay. When you are seeing very thick incisive nerve, try to avoid that. Place short implant and do it. Rarely we see, some unexplained pain or even some periapical peri-implanted deficiency. Just keep it in mind, this anatomical variations. See here, this is the first premolar area. You can see a small thing. Nothing will happen, even if you touch it, most of them nothing will happen. But we will place a shorter one. Okay. Just know this, there is something called incisive nerve which travels inside the. People think it is completely nerveless. There is no, it's not like that.